I've got a Roger.
Can I ask something? Do I have to use this phone, or is it? I have your first slide on the computer screen.
Right. So we're sitting at the Dono University in seminar room 1.3, or you can enter over GoToMeeting, this program, and you can watch the slides and hear the audio at the same time.
The audience will also come. Okay.
Okay. Sorry about the delay there. There was obviously some problem because we couldn't see that you were all already online. So sorry about this 5-minute delay. I've got a Bettina Maringer and a Roger Akers.
Yes.
Hi.
Hi.
Okay. So why don't we get started then? How can I move that from my screen? Okay, thanks so much for joining the Method Seminar session. It's the first of the new semester. My name is Kylie Thaler. I'm a member of the staff here at the Danube University Department for Evidence-Based Medicine. And I'm going to talk today about the grade system of rating the quality of the evidence. And in particular, what I want to do with this presentation today is to provide a little bit of a contrast between the grade system of quality of evidence and the ARC system of the strength of the evidence. And if we've got time at the end of the presentation, I'd like to take you on a little tour of the grade profiler software system. So let's get right into it. Hang on a second. Great. So this one slide is supposed to be basically the entire overview of how grade works. So you can see in the middle of the slide on the bottom half there's a panel, and what grade is about is writing guidelines or guideline development. And the grade process begins with that panel and also ends with that panel. So what the slide is depicting here is the panel makes a decision about what question they want to ask, and they ask it in with the PICO framework, population, intervention, comparison and outcomes. They then go through and decide which of those outcomes are going to be critical or important for their decision making. They perform or commission or try to obtain systematic reviews that assess these PICO questions for each outcome. They then produce evidence profiles using the GradePro software. So I'm on the right-hand side of the top part of this slide now. A grade profile summary of findings tables. The grade profiler is produced using this process of downgrading the evidence or upgrading the evidence, and that's what we'll go through for the most of this presentation. And then moving back down into the pink zone on the bottom right-hand side, the overall quality of the evidence across all outcomes then gets based on the critical outcomes. The decisions can be made about recommending for an intervention or against an intervention and how strong that recommendation should be. So that's where we come back to that panel and them interpreting the evidence that they've got in front of them. So I think it's a nice point to start with what is grade that a systematic review is not, I guess. So from the point of view of a systematic reviewer like me, when I get to the end of my work or my process, what I've got often is a meta-analysis like this one here. And let me just say that I made up this data, so it's not true. What you see is 3 studies on whether backflower remedies, which is a type of homeopathic treatment, are effective for examination anxiety in students. So we've got our 3 studies, and I pulled them all together and I came up with standardized mean difference, and there it is, and there's my meta-analysis. So as far as I'm concerned, I'm done. But I guess what grade does is ask us, well, what information are we missing when we just look at that particular picture there? And the first things that come to my mind about what can I not see there is, well, who exactly were the participants in these trials? Were they the kind of students I was interested in or different ones? If I only cared about medical students, were they perhaps physiotherapists, or were they even, philosophy students? Were they using exactly the type of homeopathic medication or therapy that I was interested in, or another one? And how long, for example, did the studies go for? So the point is, how do these PICO questions from the studies that I have included relate to the original question that I asked myself? Obviously, looking just at a meta-analysis in a forest plot, we've got no idea about what the risk of bias is in those individual studies and overall for the studies, whether we're missing any studies just based on the forest plot. And I guess the other thing that grade does is tell us, well, tell me more about that standardized mean difference. What does it actually mean for me? A bit of background to grade. So the grade stands for the grades of recommendation, assessment, development and evaluation. The aim of the grade working group is to develop a common, transparent and sensible system for grading the quality of evidence and the strength of recommendations. And it's an international group, over 200 contributors since 2000. Who's using grade? I guess most prominently the World Health Organization. A lot of guideline writing networks and UpToDate are using grade. And I see the Agency for Healthcare Research and Quality has also appeared on that list. I guess they're using a modified grade, as I'll explain. What's the principle? So as I said, what does a guideline panel have to do in the end? In the end, they have to make a recommendation, and the principle of grade is whether they make a strong or a weak recommendation and whether it's for or against an intervention. And the principle of grade then is to be explicit and to be transparent about how the recommendations are made. So how do we do it? We talked about this with that one overview slide, but let's go through it again. The first step is to rank the importance of positive and negative outcomes and whether or not they are critical or important for decision making and for patients. We then look at the evidence from all studies. We present the outcomes in an evidence profile and we give a quality of the evidence rating for each outcome. The importance of positive and negative outcomes. So this is what it looks like, looking at, for example, one example I've got here, phosphate-lowering drugs in patients with renal failure and hyperphosphatemia. What's probably been the most important is probably mortality, so that's been ranked with 9. The numbers don't mean anything, they just enable us in the end to come up with this ranking system. Really what's important is whether they're critical or important, and 7, 8, 9 become critical and 4, 5, 6 are important. And if they rank them 1, 2 or 3, then they basically fall out of the whole analysis. So in this case you can see mortality and MI and fractures and pain have come into the critical or important ranking, and this guideline panel had decided that flatulence for them is not going to come into their decision making about whether to recommend for or against these drugs. So the second step is to obtain all the evidence from all the studies and to pool it if you can in a meta-analysis. So that's a systematic review or meta-analysis, that's what we do, and I like the fact that in this presentation that's all you get, a little box, even though we all know that that's going to take about a year and is a huge amount of work. So it's only one part of grade, but a lot of work for those who have to do it. We then present the results in an evidence profile. So let me look at an evidence profile with you. Somebody's breathing really heavily into the speakers, but that's okay. I hope everyone can hear me okay. Is everybody still with me?
I can hear you.
Okay, great. Fantastic. Okay, so this is an evidence profile and it kind of looks rather daunting, so I'd like to just break it down a little bit to kind of take away the overwhelmingness of this slide. It's really not that scary. So what have we got here? The lines across the top, the rows, are each outcome listed here, 1, 2, 3, 5A, 5B, 6, 7A, etc. So that's not a big deal. On the far right-hand side, we've got the importance of the outcome, whether it's a critical or important one, and in this case, everything was rated as critical. On the left-hand side, we have a number of studies included for that outcome. So let's say if you've got one systematic review and you looked at multiple outcomes, then obviously you're only talking about the ones that gave you evidence for that particular outcome. The results, if there's a meta-analysis, are presented over here on the right-hand side. And Grade Profiler can actually calculate that automatically for you, or you could, for example, import it directly if you've done your meta-analysis in the Cochrane RevMan software. You can import that directly into the profiler. And then the 5 columns that you can see, well, in fact it's actually 6, but are the quality assessment process that we go through in grade. So that's what I want to go through in a little bit more detail now. And then of course at the end we end up with a grade rating of very low, low, moderate or high. So how does quality assessment work in grade, and how does it differ from the ARC approach? When we're looking at the quality overall of evidence in grade, we've got 5 factors that we can use to downgrade the quality of the evidence, and they are the risk of bias, inconsistency, indirectness, imprecision, and publication bias. We have three additional factors that allow us to upgrade the quality of the evidence, and they are dose-response association, the size of the effect, and a factor about confounding. And the nice thing is, in the ARC approach, we use the same domains. They have very slightly different names, but basically the principles are the same. So here's an example from a review. So this has obviously been done in RevMan, as you can see, and the review was about caffeine to improve daytime drowsiness. It's a hypothetical review, I presume. So what was the population is adults, normal adults, who were drinking either a coffee with caffeine or coffee without caffeine. And here we've pulled 4 studies and come up with this forest plot and this meta-analysis. So the question is, how we assess the risk of bias for this particular example. So from this same hypothetical review, I pulled out the risk of bias overview figure. And I don't know if you're all familiar with the risk of bias tool in Cochrane, but it has all the domains similar to a lot of other critical appraisal tools about allocation concealment, attrition, and randomization, etc. And you can see here that the particular studies that are of interest, the 4 that had results for that outcome, I've pulled out here, and they are, you've just got to look at it overall. So the 2 at the bottom, Ulalaza and Piazza Alerta, are mostly green with a little bit of yellow. That's low risk and unclear risk. But the Mama Kappa, that certainly has 4 domains that are of high risk, and Morricone has 2 unclear. So we consider the studies for sleep disruption, overall risk of bias in those studies. And we ask ourselves, well, is this risk of bias likely to reduce our confidence in the effect that we've found? We're allowed to do 3 things, actually. We're allowed to say no. We're allowed to say it seriously does or it very seriously does. And in that case, we either downgrade by 1 or 2 points in the grade system. They give guidance in the help. So the grade has a handbook, and you can access the handbook through the help menu of the grade profiler software. And they say, for example, if you've ended up with overall high risk of bias in a Cochrane review, then you're either going to be downgrading it very serious or serious. If you said overall unclear, then you'll either be serious or no. And if you said overall low, well, obviously you'd say no. No limitations for risk of bias. How does the ARC approach contrast? So ARC uses low, medium, and high. The definition is the degree to which included studies for a given outcome have a high likelihood of adequate protection against bias. So basically it's an internal validity question, and it's assessed through both the study design and the aggregate quality of the study. So are they poor, fair, or good? Again, this is really nice. This is taken directly from the grade handbook, accessed through the help menu. So you've got multiple ways that you can assess risk of bias, and one of them, of course, is using the Cochrane risk of bias tool. But grade also, in their handbook, provide their interpretation of saying what factors about randomised controlled trials would lead you to downgrade for the risk of bias. So you can see they've pulled out allocation concealment, lack of blinding, incomplete accounting of patients and outcomes, selected outcome reporting, etc. Similarly, for observational studies, they pulled out factors that you would downgrade for observational studies. So that brings us to the second domain in the grade system, and that's inconsistency or heterogeneity. So in a meta-analysis, obviously if you've got a forest plot in front of you, this is easy to do. So you can look at the overlap of the confidence intervals. The variation between the study results is more than you would expect by chance, looking at, for example, the p-value of heterogeneity or the I-squared. And important here is to know that the direction of the effect is not a criteria for inconsistency. So inconsistency refers to unexplained heterogeneity. So if, for example, you look at your forest plot and then you do a sensitivity analysis for subgroups or for certain factors, and you can explain it, then the grade handbook would say, okay, well then you should be presenting those outcomes separately for those 2 subgroups, for example. But if you can't do that and it's unexplained, then you can downgrade. Again, serious or very serious, 1 or 2 points. What does ARC tell us to do? Well, they call it consistency, and they say there are 3 options: consistent, inconsistent, and unknown or not applicable. That's in the case of a single study, for example. And in the ARC approach, the definition is degree to which reported effect sizes appear to have the same direction of effect. Two main elements, effect sizes are on the same side of no effect, range of effect sizes is narrow. It's a similar concept. So looking back at our example about the caffeine coffee versus caffeine-free coffee, we can see the heterogeneity here is 0%, and we've got overlapping confidence intervals, so we're pretty happy about it. And as we said, the direction of the effect is not a factor, so we're not worried about that one study being on the other side of our line of no effect there. Third factor is indirectness in the grade system. So the grade people have said, right, we consider there to be two types of indirectness that we want you to take into consideration. The first type is whether the comparisons are direct or indirect. And here I'm talking about whether or not you have head-to-head studies or whether or not you've conducted a statistical indirect analysis of some description. And then the second type of indirectness that the grade system goes through is basically the PICO question. So, and this comes back to the fact that grade is specifically used for guideline developers rather than for systematic reviewers, because I guess for a systematic review, you're less likely to have indirectness on your PICO because your inclusion criteria were based on your PICO. So, you know, unless you were including a whole lot of stuff that wasn't in your inclusion criteria, you're probably going to have a pretty direct PICO. But in the case of a guideline panel, they might not have commissioned a review. They might be using existing reviews, and that will mean that they may have evidence from a review that's a similar PICO but not quite right. So they would, in this case, downgrade for indirectness for population intervention comparator or outcome. So let's go through a few of the examples here. From, again, the grade handbook. They talk about comparison. I said that's indirect. Population, for example, talking about one type of flu, but seasonal flu, but the evidence is only for avian flu. Randomized trials of fecal occult blood testing and then extrapolating that to other forms of screening. Looking at different drugs and the dose is not quite correct, for example. And outcomes, I guess the most obvious one is that the trials have used surrogate outcomes rather than ones we're specifically interested in. So again, we get to downgrade for this of serious or very serious. And in contrast with the ARC approach here is that in ARC we rate the evidence as well as direct or indirect. But I guess ARC is written a little bit more from the perspective of people writing the reviews. So they take out the PICO concept. In the ARC explanation, they say they talk about outcomes. So if intermediate or surrogate outcomes are used, and of course they talk about two or more bodies of evidence, so indirect comparisons. So the fourth is imprecision. We're moving right through here. This is good. So what does imprecision mean? Results are imprecise when studies include relatively few patients and few events and thus have wide confidence intervals around the estimate of the effect. But what does that mean? So they say they have different guidance for authors of systematic reviews and guideline panels, but I'm going to focus on systematic reviews. Just to contrast with the ARC approach, basically it's the same. They say precise or imprecise, so there's only two levels. And they talk about whether or not the estimate would allow a clinically useful conclusion or whether the confidence interval is wide enough to include clinically distinct conclusions. And I think that's basically the same approach that grade goes through, but they go through it a little bit more statistically. So when we're talking about imprecision, we talk about the width of the confidence intervals and how much uncertainty there is about the effect. They talk about whether or not the confidence intervals include the zero effect and also appreciable benefit or appreciable harm. And they have a guidance for us about sample sizes and number of events and what they call optimal information size. What does that mean? So if we're talking, for example, hello? We're talking, for example, about okay, about dichotomous outcomes, for example, then what we want to know is whether the total sample size is lower than the calculated optimal information size, and whether the total number of events is less than 300. And this is a rule of thumb value that I'll explain to you in a second. So then we talk about whether the 95% confidence interval crosses the no effect line, appreciable benefit or harm. and the line of appreciable benefit or harm is set at a relative risk reduction or relative risk increase of 25%. How do we calculate the optimal information size? It's basically the same as what would be a normal power calculation if you were doing one trial and you wanted to know how large to have the trial based on your estimated effect size. So where does this 300 events come from? It's this table that it comes from, and this is basically looking at how many, for a certain relative risk reduction, and they've got here between 20 and so over 30% and under 30%, sorry. And what kind of control rate that you're likely to see in your trial, how many events you're going to need. And the reason they've come up with 300 is because basically for most relative risk reductions and control event rates, with 300 events you're going to be there. So that's where the rule of thumb comes in, but of course for every individual case you could do your own optimal information size calculation. When I say no effect or appreciable benefit or appreciable harm, what am I talking about? Well, this is I guess a graphic display of what that is. So you've got the line of no effect in the middle, as you'd all be familiar with, and then appreciable harm and appreciable benefit you can see as dotted lines on this slide. And you can see that there's precision in the top three because, because they don't cross the line of appreciable harm and no effect, or appreciable benefit and no effect. Whereas in the bottom three, you can see that they cross multiple lines and therefore they are imprecise. The Grade Handbook also has guidance on continuous outcomes, and basically it's the same principles of calculating the optimal information size, total population size less than 400, another rule of thumb, and an effect size of less than 0.2 standard deviations. Again, they talk about a minimal important difference, which you hopefully would know for the particular scale that you were dealing with. Or if you don't know, then they say an effect size of 0.5 in either direction. The last factor for downgrading is publication bias. You can see a funnel plot there on the screen. So basically that's what they say, to consider the funnel plot results. When there's few trials, consider the fact that large trials are probably going to be published and small ones won't, and that therefore risk of publication bias is probably higher for reviews that are based on small trials. And of course we know about industry funding. So we only get to downgrade by 1 point for publication bias. This is the first time where we don't get 2 points. And I guess what they're saying is consider the extent to which uncertainty exists about the magnitude of the effect due to selective publication of studies. And this is a feeling thing, and it's similar in the ARC approach. In fact, in the ARC approach, this is not formally scored, and they give the guidance that you should use a potential publication bias to influence your score on consistency, precision, and magnitude of effect. And they just give you the little hint that publication bias may undermine the overall robustness of a body of evidence, which I guess is quite helpful. So we're on the other side of things now. So we've started with systematic review, we've got all the evidence and we've presented a result, and we've talked about all the reasons why we would downgrade, why we're happy with what we got. And so now I just want to talk about the domains where we can upgrade the evidence in grade. And the first one is that we have a large effect. The second one is that there's a dose-response relationship. And the third one is that all plausible residual confounding may be working to reduce the demonstrated effect or increase the effect if no effect was observed. Let's go through those. So firstly, upgrading because there's a large effect. So the effect was large or very large, then we can upgrade the quality of the evidence. What am I talking about? So 1 point for large, a relative risk of over 2 or less than 0.5. Note, based on consistent evidence from at least 2 studies with no plausible confounders. Very large, +2, either relative risk of more than 5 or less than 0.2, based on direct evidence with no major threats to validity. What does ARC tell us about that? Because they use exactly the same domains for upgrading the evidence. They say strength of association, magnitude of effect, strong or weak, refers to the likelihood the observed effect is large enough that it cannot have occurred solely as a result of bias from potential confounding factors. Oh, have I put the wrong slide there? Sorry. Oops, I think I might have it wrong there. Sorry about that. So the second thing is Only dose response gradient. So the important thing about dose response is that we're in the grade system, we only upgrade for dose response when we're using observational studies, and that the observational studies have not been downgraded for any reason, so they're good observational studies. Here again, we only are allowed to move by 1 point, so we can go 1 point if we see a dose response, and the classic example is something like the INR from warfarin therapy and the risk of bleeding. Here I've got the right one. ARC approach dose response association is either present or not applicable or not tested. Third factor for upgrading is all plausible residual confounding would result in an overestimate of effect. So for example, the examples they use here for observational studies are things where you would expect something to be over-reported because a similar drug, for example, has caused lactic acidosis, and so people who are using metformin might over-report incident of lactic acidosis in their patients, but that large observational studies have failed to show the association, so therefore the effect is actually in the other direction. And the same principle is being used to judge the large trials on adverse events with vaccinations. Here we also only move by 1 point, but in the grade profiler software it asks you to talk about whether or not the effect would have been reduced or would have been increased based on the confounding that you've seen. Right, the ARC approach here is the same. Plausible confounding would decrease observed effect present or absent. And then they talk about the fact in an observational study, plausible confounding would work in the opposite direction, blah, blah, blah. The effect would have been even larger. They only talk about an effect that would have been larger. So how does all this come together? So the grade system, if there is to be a criticism of it, I guess it's that it's extremely rigid. So you have this system of going through everything, all these domains, and you basically have to keep pushing up and down, up and down. Where do we begin? If our body of evidence is based on randomized trials, we begin at high. And if our body of evidence is based on observational studies, we begin at low. We talk about the appraisal of the study methods, so the risk of bias and indirectness, and we rate down, if anything, because we can't go back up with those. We talk about what were the results and study data for imprecision and inconsistency, and again, we can only go down. We then have the option of upgrading if there's a large effect, dose response, or this reverse confounding, and we end up with a final quality rating for each outcome. What are these quality ratings? Actually, let me talk first about the caffeine and sleep disruption example that I was going through in the beginning. So we decided there's a serious risk of bias and limitations in design because remember that on that nice Cochrane risk of bias diagram that I showed you, there were all those red dots. So we're going to downgrade one level for that. No heterogeneity, that was 0%, that was pretty good, and it was exactly the question we wanted to ask, so there was no indirectness. We decided publication bias was unlikely, but there was serious imprecision because I think the effect crossed the line of no effect on the meta-analysis, and there were no other factors to upgrade. So we began at high, we downgraded for risk of bias, we downgraded again for imprecision, and we ended up at a rating of low, so low quality evidence for that. And what does that mean? So in the grade system, what that means is that for low, further research is very likely to have an important impact on our confidence of the effect and is likely to change the estimate. So you can see they're talking about two things. They're talking about the confidence and in our estimate and the actual number. And in contrast, obviously, the high means we're pretty sure we know what we're talking about, and moderate is further research is likely to have an important impact on our confidence and may change the estimate. So basically, if we knew more, we'd probably be more sure, and it might change things, but it's a may there. And very low is the lowest grade. Any estimate of the effect is very uncertain, and I guess that really encompasses quite a lot because it's pretty easy to get down to very low with a lot of the reviews that we're doing, a lot of the evidence that we've got when it's quite weak. How does that contrast with the ARC system? So ARC uses high, moderate, low, and very low. Insufficient. I didn't change that. That's my fault. That's actually insufficient, that last one. And in red, you can see where the text on the ARC descriptions is different to the grade descriptions. So you can see that they say, for example, high confidence that evidence reflects the true effect, and then further research. And moderate confidence that evidence reflects the true effect. further research may change again. Low, they removed the word very and just made it likely to change the confidence. And in insufficient, its evidence is either unavailable or does not permit a conclusion. Importantly as well, I guess, with the ARC approach is to know that it's a qualitative approach, so we don't go up and down with points that specifically describe that the risk of bias receives the most emphasis in the ASK process, that 2 people should do the evaluation independently of each other, and that all of the domains need to be transparently reported and documented. I'm coming back to this slide again. I hope that it's a pretty busy slide. It's got a lot of information in it, but I guess I hope that it's clearer to everybody now what that's all about and how that process takes place. In conclusion, for the presentation, before we go to the profiler, I'd just like to say, I guess, that the benefit of the grade process is that it provides us with a method to consider the whole picture for us reviewers of what we've produced in this systematic review, and that I get the main criticisms of grade are that it's artificially rigid, and of course that it's not reproducible. I think that's a big criticism, that there's no inter-rater reliability, and I think that information on that's going to be coming out in the next little while, and it'll be really interesting to see what happens there. But I guess with all the criticisms, what you do have to say is it is very explicit and it's very transparent. And as anyone who's used the grade profiler will know, you have to justify every single decision that you make with the footnote. So you've really got to put your cards on the table, so to speak, when you're using the grade system. I'd like to just make a few acknowledgements about this presentation. I have the slides and teaching examples, or some of them, from Nancy Centezo and Holger Schünemann, and also from the Grade Profiler Help Guide. And some of the information about the contrast between grade and ARC approaches is based on a presentation from Nancy Berkman and Holger Schünemann at the ARC conference in September this year. So, are there any questions? I'd like to just have a little bit of a talk now, and then maybe we can have a quick look at the software if anyone's interested. Can I take any questions? Is everybody still there?
Oh, I'm sorry. Hi, Kylie. This is Tanya from UNC.
Hi, Tanya.
I had a question about the whole direct versus indirect, and I was just curious if either grade or ARC, how they felt about a mixed treatment comparison where you'd have both types of evidence, and if you could make the case either way that it could be downgraded or kept upgraded, or sort of what people are thinking about those types of networks.
Yeah, I find that a really good question, and I'm actually really happy if anyone else wants to jump in who knows the answer. My feeling is that it's in neither of the approaches is explicitly talked about. Does anyone have any other idea? Gerard?
Hey, Kylie, this is Dan. Sorry I joined late. I was in another meeting till 10:30, but I have some thoughts about that in another question. But I think there's a missing category that it's not completely direct or indirect. I think it's a mixture of the two. So it's something that we don't quite have a category for in the ARC system. But I can't remember what we actually did when we came across that for the RA report. If we just wrote that in, or if we I can't remember if we called it indirect to err on the conservative side, or if we wrote in like indirect and direct or something like that.
Yeah.
We only had one head-to-head in that, so it was kind of a mostly indirect.
Yeah, right.
Yeah, I wonder what antidepressants, I can't remember what you all did, because there was a lot more direct evidence within that network analysis.
Right.
I don't know if you guys wrote in direct and indirect or what, but I think that's what I would tend to do going forward, is write both or mixed or direct and indirect, and footnote it with an explanation.
Yeah, so there's no automatic up or downgrade right now. Like it's just, you can justify either. Because some people might look at that and say that's really mostly indirect, so I'm going to downgrade it.
I think there is. Right now somewhat of an automatic downgrade. Yeah. I think there is. I don't know that that's written anywhere. That's the way I think most people would look at it, though.
But that might not. Yeah.
And I think the reason is that there are enough examples when some indirect things don't match head-to-head evidence, and there's still some uncertainty there. So I think people think it's downgraded somewhat.
I think looking at the ARC guidance, when it says it uses 2 or more bodies of evidence to compare interventions, I guess you probably would have to downgrade for indirectness there. strictly speaking.
Yeah, yeah.
Yeah. I guess a good thing about the ARC approach, though, is that you can be a little bit more on the fence than you have to commit to minusing points or not in the grade system.
Yeah, it's interesting. So my question, Kylie, is it's interesting, and I've seen some of this type of presentation before with how with grade, you're sort of doing these points up and down, and when people describe the ARC one, they're sort of saying you're not doing that. But I think practically when people do it, they actually are doing that, and they're sort of starting with, if you've got a group of trials, I mean, I think they're starting with basically the same approach in that they're saying if we've got a group of trials here, we're starting at high, and if it's low risk of bias, direct, precise, and consistent, we're staying at high. If one of those things goes down, we're dropping down to moderate. And if multiple of those things go down, I think that's where there's some inconsistency about whether people drop down to low or whether they have some flexibility to stay at moderate or whether they even drop as far as insufficient, depending on what the second thing is that drops down.
I think, I think that's absolutely correct. I think that that's probably where the big difference is when are you dropping then from moderate to low when two things come up. Yeah. Yep.
Anyway, I guess that was more of a comment than a question.
Yeah.
Maybe the question was, is that, do you agree? Is that sort of how you've done it and how you think about it, or do you think that there's something different going on?
No, I think that's exactly how it is, and I referred to this this ongoing research. I know that there's a study going on right now about this inter-rater reliability with grade, and they're comparing it to, if I'm allowed to talk about it, I hope I am. This is a group in Canada, and they're comparing it to just using a visual analog scale, basically. And I think that's going to be really interesting to see what comes out. So, going through this whole rigid system or jumping up and down or just giving kind of, your feeling, having actually thought probably about all those domains anyway, because that's what we're all doing.
Interesting. Is the scale, what's the scale go from? Does it go from
1 to 100?
Oh, wow.
Yeah, so yeah, we'll see.
That will be interesting.
Yeah, I think they're presenting that in January at the grade working group, so that will be really interesting. Does anyone else have any questions or any comments? Anyone here? My exhausted looking colleagues, because it's the end of our working day. Gerard, I don't think managed to join us, or I thought he was, but he's jumped off. He's actually in London at the moment, so I think his internet connection is not that great. No. Okay. Well, look. This is. Does everyone? Is everyone? Who have I got with me? I've got some RTI people and some UNC people. Have you used the grade profiler software at all?
At all? Probably just me. I'm probably the only one who's used it at all, but never for an actual report. More just in a workshop.
Right. Yeah. Yeah. We've always had the problem. So we've never used it for guidelines. We've used it for we've been asked to use it by a few people who've commissioned work from us, and then we've had to produce grade stuff in the end. But the problem I guess we've had with it is I personally find it, and I hope you can see it on the screen, really nice to use. I think it's really great, and I think it's really excellent. You've got these great help menus. If you click on here, it gives you go straight to the help menu. And it gives you all of that stuff that I went through. So I find that really useful. But I guess what it is it's totally inflexible. You have to produce a perfect grade evidence profile. The only other thing that it does allow you to produce a Cochrane summary of findings table, if that means anything to you. But basically, it's difficult to change things. So that's where we probably had the most difficulty with it. Do you want me to quickly go through it, or because I think
that would be great.
Okay, well look, this is a profile that I opened up. It's it's about glucosamine versus placebo for osteoarthritis of the knee. I think, I'm not sure if it was the knee, but you can see there. This is the overall heading, and then this is the comparison. So if you go here, what you can do is you can choose the format of the question you want to ask. So should intervention be used for? Should intervention versus something be used for? Used in, etc. And then once you've chosen that, it asks you in the intervention comparison and health problem to input the data, to input whatever you want, and then that comes up with an automatic question at the top here. And then the title of the summary of findings table will be there too. And then what it does is it asks you to set outcomes. So you can click on this add outcome, but I've got some here already. So for example, then you list all of the outcomes down here. And it kind of guides you through the grade. So let's say we've got pain. So that's my first outcome. And we called it pain. We said what it was assessed using a number of different methods. That's pretty average. We could say, for example, it was a visual analog scale. Are you seeing this? Because we probably don't need that bit. Right. Then we say, okay, what happened? We've decided this, of course, in advance. What rating do we give to the importance of it? Was it critical? If it was a 6, it'll come up here as important. And I guess so I talked about critical and important, and why that's important here with these 1, 2, 3 to 9 is that that's how it comes up then in the evidence profile in that exact order. So even though a 9 and an 8 are both critical, that will affect the order here in the profile. We look here then at how many studies we have, and important again, the first point of lack of flexibility is you can only choose between randomized trials and observational. You can't choose both. So they assume that if you've got randomized evidence, you have ignored all observational evidence. So basically, which is going to be the case probably if you've got 18, but sometimes we have had to, for example, we did a recent report on, Anna, help me here, was a axillary dissection for sentinel node positive breast cancer. Right, and we had to produce a grade profile, and there was only one RCT, right, but there was about 4 or 5 observational studies, and we wanted to incorporate those too because we felt that they did provide something valuable. So that was really hard in the grade profile to do that, and we ended up having to make multiple outcomes when we made outcomes for RCTs and outcomes for observational studies and did them separately, right? Yeah, so that was how we solved that, but like I said, it's hard. Then you can put in here the length of follow-up, whether it's a range, a mean, 6 months, weeks, days, whatever it is. So, and then based on, so this is what you've got your meta-analysis hopefully already, and you just go through the risk of bias assessment, and every time you say no, look at that, automatically pretty little picture changed. We made this one serious, and of course once you downgrade something, you have to put a footnote in. So you can either choose a footnote that you already let's say you've got the same reason as what you had already said before. What have I downgraded for here? Indirectness, right? No, I didn't downgrade for that. So I'd have to put in a new footnote, and I'm just going to say it is indirect because I say so. Save, and there it is, so we can save it again. And then at the bottom of the evidence profile, you've got all of your footnotes there automatically present. Same thing there. Same thing there. Go to summary of findings. Pooled, not, so this is the actual results, and that'll come up in, this is actually, I think, presented with a summary of findings table, not a thing. Anyway, so basically you can say if it's pooled, not pooled, if it's a range of effects, if it's from a single study, not measured or not reported, and what kind of outcome it is. If it's a dichotomous outcome, then you put in events and no events. And if it's a continuous outcome, obviously you work with your means. And as I did mention in the presentation, what is really cool about this is you can, if you've got a RevMan file, so if you've done everything in RevMan, you can actually import directly from a review manager file, and this is all automatically in there. So that's really good, and the reason that they do that is because Cochrane authors are expected to use the grade methodology when they are doing their conclusions of their reviews, so they basically had to incorporate them, between each other. Yeah, and that's about it, really. Any questions? And Angie, you said did you have any particular specific problems with the profiler? No? Back to the quality assessment. You guys at UNC or RTI, have you had any particular problems with the profiler?
No, we haven't used it hardly at all.
Uh-huh.
Are you guys using it routinely for your systematic reviews that you do? Like, obviously, if you were doing one for Cochrane, it sounds like you are, but what about for DERP
No, basically, would be the answer to that. Yeah. Yeah, so that's what a Cochrane summary of findings table looks like. So if we just click here and make it into a grade evidence profile, it's exactly the same information, it's just presented slightly differently. So that's what it looks like as an evidence profile. That's what it looks like as a Cochrane summary of findings table. And this seems to be, for the ACCP, they seem to have some other kind of format. So here it is. You can see actually the footnotes. I don't know what the difference really is there, except that that's just mixed around a little bit. It's kind of handy. You know, my bottom line is this: if you're working only with RCTs and you've got good pooled data, then I reckon this is great. I think it's really the problem is when you are dealing with we've got observational evidence, mixed evidence, and everything gets a little bit more wishy-washy. Then because it's so rigid, then it's hard to work with. Do you guys at RTI have any experience with this?
No, I don't personally.
Okay. Well, I guess I probably should let everyone get back to work. So I guess we'll call it a day if that's okay with everybody. Thanks so much for listening in. I really hope that it was some food for thought and some new information there for a lot of you.
Thanks, Kylie. That was great.
Thank you, Kylie.
I think the next method seminar is in about 3 weeks. Okay, great. And I think someone from the US is doing that, and I'm really looking forward to participating and listening in for once. Okay. Then have a lovely working day. See you.
You too.
Thank you.
Bye.
Bye. Bye.
Bye.